just a bit of background. So me and Andy have known each other for 25 years. You ever know me in med school, I think? And then I saw you on same year in registrar all the way through. And he can drink me under the table. Yeah, so my argument really is for the MPM approach. So I do have disclosures. So the disclosures and the ankle fracture system is around the postural mal, so that is definitely relevant. So first of all, take you back. So I've started on the postural mal journey about 10 years ago, and this has been a decade long of research, over 20 publications, Hunterian professorship halfway through. And what I presented in the Hunterian professorship, I now believe is wrong, and I've moved my way because on that there was a posterolateral approach, which I don't use anymore. In the JBJS America, that's where I presented our findings after we instituted an algorithm. And on that algorithm, which our results got better, and on that algorithm, our approaches were, as you can see here, posterolateral, and posteromedial. MPM was only really when we were doing the medial aspect of the 2B type fractures. However, I have not used the posterolateral now for 4 years. And this is what I use, and there's reasons why I use this. And the more studies we've done over the last 5 years since my Hunterian has been based really on why we shouldn't do the posterolateral anymore. So hands up here who fixed the postural mal fracture. Okay, majority of people. Okay, hands up here who's used the posterolateral approach. Okay, majority of people. Hands up here who know where the perineal artery is. Okay, it's very few. And so in the OTS, it was even worse than that. So I would say that the perineal artery is the most dangerous aspect of the ankle fracture because no one knows what it is. It's very variable. And also, not only is it very variable, it is also a risk. I'll come back to that later. Okay, so the medial posteromedial is sneaking in the back of the tibia in between your tibialis posterior and your FTL. If you've got a 2B fracture, you can come in the other side of the tib post. But it's really easy. Your neurovascular bundle is superior to you towards the Achilles, and the FTL is essentially a windbreak between you and the neurovascular bundle. So it's a safe aspect, and you come nowhere near the perineal artery, which I'll come to later. Posterolateral approach, you come through the sural nerve, okay, and there's a study that has been published recently of a 40% chance of sural nerve injury as a consequence. And as you go down further, the perineal artery and its branches are in the way. And I would also say it's a low yield, high risk approach. So low yield, you can't do the majority of things you want to do through it. So positioning wise, so this is my usual approach. We'll call a semi-prone recovery position. The other knee bent up the way. The leg that you operated on is in a prone position. Beneath this is happy because it's the lateral on the top end. However, you can also do it through the supine approach. It's quite easy to do your MPM, and if you're doing a tricolumn pilon, it's the way I do it. So you just put your sandbag underneath the contralateral hip. You can even bend it up into a figure of 4, and you can get it all the way across the back. So seeing in your fracture and reducing the fragments is quite easy through this. Instrumenting and putting your plates on, it becomes a little bit more difficult. So you hear me curse a bit more when I do it. But apart from that, you can actually then move it, the sandbag on the other side, and get into the lateral very easily. So you come into the front of the tibia, or the front of the syndesmosis. This is actually the easiest way to do it, and this is the way I do it for those cases. There was a paper that published in FAO just a few weeks ago showing that supine position, PM fracture through the MPM. They done a CT scan of all of them post-op, and they'll take a reduction within 2 millimeters, 94%, which is extremely good for any follow-up on these patients. Caution of doing this, the posterolateral supine position, because what usually happens, you try to sneak behind and peek around it, you malreduce it, and you don't see this area, so you can't see that you malreduced it. And then when you're trying to instrument, you're going through the perineal artery. This is the kind of cases that we were getting when we first started fixing them in our unit, where people were malreducing it, sneaking behind the fibula. You can see a direct lateral approach to the fibula there, and this is the CT scan showing that malreduction. Okay, so exposure-wise, what can you expose this? This is one of my papers a few years ago. We were looking at what was the best point to fix these, and we found that 70% you could get to the fracture line through the posterolateral, but it's much better for the MPM. And you can see here that your MPM come in this area, which can get you to the front of the tibia, all the way to there, coming through the posterolateral, you'd only get to this corner here, and you can't see any of the soft tissue on this side. But you can see, as compared to your 2A is fine through the posterolateral and a simple distal fibula, but all the other ones are much better through the other approach. Okay, this is another paper we looked at, done a cadaveric study, put some K-wires in through different approaches, then measured the size of area you can get to. And you can see the MPM double the amount of exposure through the same size incision of 7 centimeters. And if you compare this to the size of the fracture fragments, so the MPM is the only one that comes near the type 3, for example. This paper, different nomenclature from me, as in the MPM and the PM come around the neurovascular bundle. I won't advocate that, I come in this area here. But even with this one, you can see the retraction force when you come into both medial and lateral is much better through this medial area compared to your posterolateral approaches. Same here, the retraction forces go medial. The retraction force is much more difficult. So this is the approach, very simple. 1 finger breadth behind the tibia. You can actually bring it forward. I'll show you that now. If you want to get to the front of the tibia, on the medial mal or a type 2B fragment or a medial column pilon. Some other people are sort of Lucky and Anand do a different incision here and then another one there. I bring it all around and it's on your vascular pedicle, so it's actually very easy to do and very safe. You come through your tib post sheath. You can see here, neurovascular bundle is back here. This is the FDL and tib post. You find one of the tendons, open up the sheath, and then you just move it and get to the periosteum. This is your 2A fragment. So this is all the back to the lateral corner of your posterior tibia. And you can see there, moving the tib post the other way to get to the medial tibia. So you can get to see this bit as well. And you can bring it further forward and get to your medial mal and even to your anterior collicular, so you can expose pretty much all the tibia. And again, it's a very safe approach. This is kind of metalwork you get in even through this small incision, and it's very easy to repair afterwards. So just an example. So this one, it was a bit of a malreducence. Most when screw broke, it actually reduced itself. But can you see here? This has been over-egged. So much so that it's actually even impinging on the fibula. So when someone said, can you get to the lateral aspect of your tibia? You can actually go even further if needs be. So it is very easy to do. Also, it's on your fasciotomy line, so you can unzip it all the way to the top. So you're doing a case like this, just in a supine position, where you can get to the front of the tibia. It's from a few years ago. I don't use this type of metalwork now. And fixation at the top end, you can do that through these incisions because of the fasciotomy line. And even your medial column pilons, as you can see here, and also because it's not underneath the incision is not over the top of the metalwork, it's a lot safer on our medial incisions. Okay, so to put this through, so vision and posterolateral fragment is easy through posterolateral and MPM. Vision of the PM fragment, you can't through your posterolateral. Die punch outcomes. So there's a few papers on this recently. This was back in our JBS paper. We've done it again and shown that those with a die punch actually done a lot worse. Die punches are usually underneath this area, underneath the posterolateral, and to get to that area, coming through this area, you can't open that door because the hinge is in the wrong place. So if you want to get to the die punch, the MPM allows you to open that book. Tib post entrapment, we've done a lot of work on this over the last few years. So when we looked at all our already fixed fractures, unfortunately we saw that a lot of them had tibialis posterior, which we hadn't recognized going through the posterolateral approach. And if the fracture line enters the tib post sheath, there's a greater than 40% chance that the posterior tibial tendon is entrapped. So if you're not going in through the MPM, you're not going to be able to see and treat that if you need to. And this is showing that fracture line entry in the tib post sheath. Really look at that on your axial CT. Medial safe zone. So this area, if you put any metalwork down this area, so when you haven't seen it, you're essentially going to be on your tib post area. This was a paper that we done in the CAD lab showing that this area is where the tib post sheath lies. Okay, so if you go from front to back and you're in this area, you will essentially be in the tib post if you go through that line. So for example, this is a case that was done in our unit. It was a posteromedial rather than MPM approach. They didn't see the medial aspect and they put the screws in. And what they've done is put the screws through the tib post all the way down. That patient couldn't get the medial aspect of the foot to the ground and had to have that plate removed. If you're doing the MPM, you can see all that. You can see where the tib post is lying. This is again in the cadaver lab. This is the top area of your tip or sheath. So anything below that area around this is likely to be in the tip or sheath if you haven't seen it. And this is your safe zones. To clean out the soft tissue, as I said, the MPM is the easiest for that. Fixation of a high accommodated fibula. Jane argued with this last year, said it's very easy to fix the proximal fibulas through the posterolateral approach. I highly disagree with that, having done many over the years. As you can see, it was on my algorithm. It was always a sweaty venture. So in a case like this, we've got a high fibula coming up, doing a very long posterolateral incision here, and taking out your perineal artery and its perforators, and then trying to balance on a plate on top of this is very difficult, but doing it through the direct lateral is very easy. Similar case, you can see a lot of comminution. So coming through this, the posterolateral, trying to fix that and do all this through that incision is virtually impossible. But when you can do it through this, you can get a very easy lateral fibula and put your syndesmotic fixation in. Anterior fibula or syndesmosis, you can't get to this. So if you've got all this mess at the front here, doing direct lateral, even a little bit further anterior, I'll show you, I bring my incision a little bit more anterior on my fibula, can get to the anterior profound. You can even do profundoplasties through that. So this is where I make my incision here rather than the direct lateral. And by doing so, you can see into your syndesmosis, you can get across the front of the anterior tibia. And you can even fix the fibula from the front if you're doing an anterior pilon. You can see. So for example, this case here, we got a flipped segment of the anterior fibula here. And so you cannot get to that through the back. But you can through the side. Okay, similar case here, we got a segmental fibula. Very commonly did posterior mal, segmented fibula, trying to do that through the back. Again, you're going to really struggle to get that length when you can do it easily again through the direct lateral. So judging fibula length, this has happened a number of times in our unit where people have gone in through the posterolateral incision and then really struggled to get length of the fibula. And help has had to be called. Doing this through a direct lateral is very straightforward. So this is the case that this went wrong. So you can see a postural mal fracture, quite straightforward. So through a direct lateral MPM to get to that. My colleagues have gone through, they haven't fixed the distal aspect, treating it as not a rotational pilon, but an axial loaded pilon, which it's not. And then put this on the lateral side, and you can see we can start opening here and narrowing of this lateral column. And the reason for that is your short fibula. So in this case, I've had to take back to theatre and do a lengthening procedure, just scarf osteotomy to lengthen to get that back in the right position. And then revision or delayed presentation. So this is the reason why I started the MPM, because I was doing so many revisions, and you just can't do your revisions through the posterolateral. You just cannot. So this is the case that was done elsewhere, sent to our unit. It's a very typical high, not a true lateral on here. We got a high, the high posterior mal and over squeezed fibula. We know this is out the back. And lo and behold, you can see your CT scan. This has gone out the back. And this was him post-op. It's one of my colleagues' cases, be it that was done elsewhere, and you can see the external rotation. Initially, when he went to get a guide to do the osteotomy, this is the guide that was designed. It was actually delivered, but to try and get that and put a saw through there, you essentially had to do your incision as high as up as the knee. But when you can come through the MPM here, you can actually get to this. So we actually didn't use the guide at all. I give him a hand on it to get that back in the right position. It's never great through doing these revisions anyway. So as you can see, the posterolateral is not great, but the MPM is great. Okay. So from my perspective, it's the reason why I have changed. So complications, I'm almost finished. So the complications. So this is one of our papers. We looked at the posterolateral approach in the literature. They say about 15% will have a complication. This is higher if you could take the recent study that said 40% sural nerve, but then you've got some hidden complications they don't talk about. So we presented this in Beaufast last 2 weeks ago, where we looked at this classification called the Clavian Dido complication. And you can see up to 3, these are all the ones that you essentially come back to clinic for a bit of an oozy wound, or so it's not infection, but it's the wounds haven't healed very well, or so it takes a little bit longer. So a 1A, for example, is one more clinic appointment down to a 3, where you actually take them back to surgery. And if you look at those, so your MPM sort of has an 8% complication rate compared to the 66% complication rate of your posterolateral. If you do a regression on it, like sort of the main reason for these complications is your approach. Nothing else really mattered. And that's the last thing I said I'd come to is the perineal artery. So the perineal artery can be sort of your main blood supply to the foot. So in 10% of the population, it is your main blood supply. There's these hidden complications, which one is FHL necrosis. Anyone here seen a case of an FHL contracture after a posterolateral approach? Got one at the front here. Okay. So I've heard these sort of around the country, and I'd never seen it until recently. And when I first presented Posterior Mal as a debate against Mickey back 5 years ago about to fix the Posterior Mal or not, sort of Tim Chester, which is one of Andy's colleagues, said sort of all these posterolateral approaches, sort of they're very long, and they all come back with contracted FHLs. All right? And the reason for that is because your perineal artery is the only blood supply to your FHL. You've got multiple perforators, up to 6 perforators going up. You take them and you sweep your FHL medial to get your approach. The bigger incision, you're going to take all them perforators. Even so, with this one, so this study was actually on taking your vascularized fibula graft for mandibles, and every single one of them had a contracture of FHL because they've had a necrosis. So this is one in a paper showing this necrotic FHL and this contracture of the FHL. This is one from that was done in Thailand recently, came to our unit. And look at your FHL here. Sound of that one. It's the grey FHL, because our FHL is dead. And the other one is the communicating branch. So the communicating branch between your perineal artery and your tibial artery. So we do the advanced AO course, and over the last 2 years, I've got them to dissect the perineal artery when we're doing the approach to the back of the ankle, and then to find this communicating branch, and even put your finger on it and roll it, and it's a big branch. Okay, what it is this one here? It's an artery that communicates between your perineal and your posterior tibial artery. This one, you can see often, if you've got peripheral vascular disease, your tibial artery is all dodgy, and then then here you got your perineal artery that comes through the communicating branch to supply the rest of the foot. So if you're going through a posteromedial or a posterolateral, you'll come through this. You'll either take it or put your plate on top of it. And I got my, he only got up to 218 on Sunday night. We got 900 studies going through my academic fellow, and large communicating branch present in 67%. So 67 to 31% of, but if you have peripheral vascular disease, that went up to 80%. So if you've got peripheral vascular disease, this may be the only blood supply to the foot. This is one of them. Okay, you can see here coming down, sort of no tibial artery, that's sort of nose above it, and your perineal artery is supplying that. But if you come through the MPM, you come underneath it. You come underneath both the arteries and the communicating branch. So it's not an issue through the MPM. So this is a study, this was a case that was done by my colleague Togay down on the South Coast, and he was very gracious to send me this. So what happened? So he left in his words, he left the registrar to put the plate on. They'd had a nice approach, he was very happy, and then the foot went white. So he was doing it not under a tourniquet, so you could see it. And then he had to go back in, take the plate off, and sneak it underneath. You can see where you'd have to revise it. And this was the CT angiogram afterwards. And what's quite interesting on this one, watch now, you'll see little blushes around it. So there's your anterior tibial artery, here's your blush, this is your perineal artery perforators which have gone. Okay, these are the blushes because your perforators to your FHL. There's another blush there. Keeps on going down, and then when it gets to the bottom end, get in there shortly, these more blushes because the perforators coming to the bottom end, and then it's where it goes down where the plate is. Where it's almost here. Oh, it's not allowing me to go down. Okay, so and then it goes down as far, and that's where the plate was. But if you could do the MPM, you can see you can sneak underneath it. So it's not an issue. So this was my algorithm. This is my algorithm now, essentially. MPM direct lateral. So the case that Ennis just showed, so for that case, if you agree it should be fixed, it looks like it needs to be fixed. You can get to all that comminution, you can get to the die punch underneath, you can get to them big fragments you need to take out either through the fibula or through the MPM, you can get to it all. And also, you're then not risking sort of the problems, if, especially if the peripheral vascular disease. Thank you.
All right.